Welcome to Owning the Oxylog or Dominating the Vent. Both those titles are borrowed and will be explained shortly. Ventilator talks classically fall into either ventilation theory or ventilator knobology, with very little overlap between the two. The Oxylog guidelines in your hand is an attempt to marry both. They're attached to the Oxylogs as both a memory jog and a cheat sheet for bedside education. If we set ourselves the standard that the consultant spends 5 minutes going through these guidelines with their registrars and nurses in every intubation and at every handover, our patients will be receiving the highest possible care and our registrars the highest possible training. It's what we ourselves would expect as patients, which is the best way of defining acceptable levels of care. The theory was provided by Scott Weingart's excellent Dominating the Vent talks, which were then superimposed into the Oxylog 3000's 108-page manual. These were then run by the Austin and the Royal Children's Hospital ICUs for vetting before going up on Life in the Fast Lane as a post titled Owning the Oxylog. Since then, these guidelines have been adopted by Adult Retrieval Victoria, Sydney HEMS, and Royal Flying Doctors Queensland, amongst others. Let's start with volume control ventilation, as that's what most adult emergency physicians are used to. All intubated patients in this talk are assumed to be analgosedated enough so as to be apneic and not fighting the tube. The first thing you have to do is figure out what sort of patient you are ventilating. There are two choices: those with obstructive lung diseases like asthma or COPD get an obstructive strategy, and everyone else gets a protective lung strategy. Let's talk about the protective lung strategy first. The protective strategy was derived by the ARDS-NET Collaborative. In an RCT comparing ventilator strategies in ARDS patients, the protective strategy of low tidal volume, high PEEP, showed an absolute mortality benefit of 8%, or a number needed to treat of 12 to save one life, when compared to the old standard of a tidal volume of 10 to 12 millilitres per kilogram and low PEEP. Further studies on less sick patients didn't show a mortality benefit, but did show benefit with regards to biomarkers of lung damage and ventilator-associated pneumonia. Though 6 millilitres per kilogram was initially called low volume ventilation, it's now called normal tidal volume ventilation, in recognition of the fact that tidal volume averages 5 to 7 millilitres per kilogram. On the Oxylog, the default setting when it is turned on is for volume control ventilation, and the VC button lights up. The first setting the manual wants you to set is the volume knob. Set it for 6 millilitres per kilogram of ideal body weight, which the ARDS-NET protocol based on a patient's height. If you look at the guideline, you will see that for a 5'10" man, this is 440 millilitres, considerably less than what was used in times past. Once you dial in the volume, you need to check the screen to see that volume is actually being delivered. With this smaller volume, a faster respiratory rate is needed to maintain minute ventilation. Start around 16 to 18 breaths per minute. You will titrate to CO2 pH later, as you would normally do. Next is the Pmax knob. It doesn't set a pressure, it sets an alarm to go off if the pressure in the circuit exceeds the nominated value. The nurses refer to it as a PIPS, or peak inspiratory pressures. Unfortunately, it does not relate to anything useful to the patient. Medical school teaches us that the size of the trachea was the width of your little finger, and the surface area of alveoli is about the size of a tennis court. It follows that if you shove a fixed volume of gas through this system, you can expect a very high pressure as that volume passes through the trachea, which then drops when it reaches the alveoli. High pressures in the alveoli damage the lung. High pressure in the trachea doesn't. High PIPs in themselves are meaningless. Thus, crank the Pmax to 40. Next is the FiO2 knob. We are all designed to run on 21% inspired oxygen. So if we are hypoxemic, it's almost never from hypoxia. It's invariably a VQ imbalance, especially if there are acute interstitial changes on CXR. While leaving the FiO2 on 100% will increase the O2 sats, it doesn't address the underlying pathophysiology, and there is a growing body of evidence of the toxicity of long-term 100% O2. The pathophysiology of collapsed and fluid-filled alveoli is addressed by what is called the staircase recruitment maneuver. Drop the FiO2 down to 40%, and with the PEEP on a default of 5, inch your way up alternatively on your PEEP and FiO2 as per the ARDSNet PEEP FiO2 scale to reach an oxygen sat between 90 and 95%. So if an FiO2 of 40% and a PEEP of 5 doesn't give you adequate sats, go to 40% O2 and 8 of PEEP. If that still doesn't cut it, increase the FiO2 to 50% while the PEEP remains on 8, and so on until you get the sats that you want. While most emergency doctors are comfortable with PEEPs up to 10, they are less so with PEEPs above 10. Don't be. In the ARDSNet protocol, the PEEP FiO2 scale went up to a PEEP of 24 on patients that were far sicker than ours and still showed a mortality decrease. That said, our ICU didn't want us going above a PEEP of 15 without talking to them, which is fair enough. Earlier on, I said the Pmax or PIP alarm was meaningless in itself. That is not to say it should be ignored. High PIPs may just be in the trachea, but it may reflect high pressures in the lung itself. You can figure out which it is by doing what's called an inspiratory hold maneuver, by holding down the inspiratory hold button. It does what it states. A breath is taken and held, allowing pressure to equilibrate across the entire lung. This is called the plateau pressure. A plateau pressure of less than 30 centimetres is safe, and the high pressure is in the trachea and may be fixed by suctioning the tube. If the alarm continues despite the suctioning, raise the Pmax alarm to 50. If your plateau pressure is greater than 30 centimetres though, lung damage may occur. The treatment for this is to lower the tidal volume to 5 millilitres per kilogram and even 4 millilitres per kilogram if plateau pressure remains high. Plateau pressures should be measured and documented every 4 hours and after every change in settings. The obstructive strategy is for patients with asthma or COPD, where the issue is gas trapping or breath stacking. Thus, the strategy is similar but different. Volume is still dialed in at 6 millilitres per kilogram ideal body weight, as per the table. The respiratory rate is set lower to allow time for exhalation. Rather than 16 to 18, start at 8 breaths a minute. This obviously causes CO2 retention and respiratory acidosis, but given that the risk of lung injury outweighs the risk of moderate acidosis, pH greater than 7.1, it's permissive hypercapnia. To allow this to occur, you need to have the patient bombed to a RASS of -5. While initial paralysis may be necessary to get control of the situation, avoid repeated paralysis as it can cause a polyneuropathy. Pmax is still set at 40 for the same reasons mentioned above. The FiO2 is titrated to give an SpO2 89 to 95%. PEEP is interesting in these patients. There are two schools of thought with no evidence that either strategy is better than the other. One school is the zero PEEP or ZEEP school, to which our ICU belong. They want to minimise accumulative pressure in the lung. The other school believe in measuring the patient's intrinsic PEEP and setting the ventilator's PEEP at 2/3 of this to keep the airway splintered open in light of raised intrathoracic pressure. The intrinsic PEEP of obstructive patients can be up to 14, so they may get PEEPs of 8 or 10. Despite this huge variation in practice, there is no difference in mortality. Keep this discussion in mind when we return to the obstructive lung in both pressure-controlled ventilation and non-invasive ventilation. At the end of the day, the Oxylog can't measure intrinsic PEEP, and our ICU prefers zero PEEP, so zero PEEP it is. The next setting you want to modify is the IE ratio. This is done in a roundabout way. You dial down the inspiratory time while keeping an eye on the IE ratio. You want that to be at least 1 to 4. The next setting you modify is the slope. This is the inspiratory flow rate. The default setting is a modest incline. A steep incline is a fast inspiration, which allows a further prolongation of expiration. Next, it's time to look at your flow curves by pressing the Curves button until you get a screen that looks like this. Above the horizontal is inspiration, below expiration. Here we can see that the expiratory flow curve doesn't reach baseline or zero before it's interrupted by another inspiratory curve. As you might intuit, this means the patient hasn't fully exhaled and thus is breath stacking, which can be life-threatening. The treatment is to lower the respiratory rate further. The minimum would be 4 breaths a minute. Finally, perform an inspiratory hold maneuver by holding down the inspiratory hold button. If your plateau pressure is greater than 30, lower the tidal volume to 5 milliliters per kilogram and even 4 milliliters per kilogram if plateau pressure remains high. Plateau pressure should be checked and documented every 4 hours. If you have a normal plateau pressure, ensure the patient has adequate analgesic sedation and the tube suctioned. If this doesn't resolve the alarm, dial Pmax up to 50. Now, pressure-controlled ventilation. Not intuitive for those who have grown up on volume control, but necessary if you are going to be using an uncuffed tube in kids, as it compensates for the leak which occurs with uncuffed tubes. Speaking of kids, the PC guideline you have is designed for kids, but just to simplify the discussion here, we're doing the 70 kilo, 5'10", 17-year-old. There is one key concept to understand, and then pressure control ventilation is easy. And that concept is Boyle's law of gases. This states that pressure is inversely proportional to volume. In terms of ventilators, what that means is that in volume-controlled ventilation, you need to set pressure alarms, and that in pressure-controlled ventilation, you need to set volume alarms. What you are trying to achieve is the same. You still have the same strategies, protective and obstructive. Let's start with protective. As mentioned, the Oxylog's default ventilation mode is volume control. To switch to pressure control, press and hold down the PC button. In PC mode, the volume knob doesn't work. Volumes will be dialed up with the pressure. Set the respiratory rate knob at about 16 to 18 BPM, titrated as per normal. Set the Pmax knob to 40. Remember, this is a pressure alarm only and doesn't necessarily measure anything important to the patient. The FiO2 knob and the PEEP are titrated in a staircase recruitment maneuver as per the ARDSNet PEEP FiO2 scale until you get an adequate O2 sat. The next setting to set is the inspiratory pressure. How much pressure? Enough to get 6 milliliters per kilogram ideal body weight. So in a 5'10", 70 kilogram male, enough inspiratory pressure to get 440 milliliters per breath. If your nurse says, "Doctor, your pips are high," you do an inspiratory hold maneuver by holding the inspiratory hold button. If your plateau pressure is greater than 30, reduce your tidal volumes by 1 milliliter per kilogram and check the plateau pressure after 15 minutes. 4 milliliters per kilogram is the minimum. If you have a normal plateau pressure, ensure the patient has adequate analgesic sedation and the tube suctioned. If this doesn't resolve the alarm, dial Pmax up to 50. Next is the obstructive strategy in pressure-controlled ventilation. As before, the volume knob doesn't work in PC mode. The respiratory rate should be set at 1/3 to 1/2 of the normal rate to allow time for exhalation. In an adult, that's around 6 to 8. As before, we need enough analgesic sedation not to breathe up, a permissive hypercapnia where the pH is greater than 7.1, and to avoid repeated paralysis. Pmax is once again set to 40. FiO2 is titrated to sats of 90 to 95%. RCH ICU are not of the zero PEEP school. Indeed, they hadn't heard of it. They use a PEEP of 5 on their asthmatics. Because paediatric patients are whom you will be using pressure-controlled ventilation on, and given that they are likely heading to the Royal Children's, we are recommending a PEEP of 5 too. Inspiratory pressure is dialed up to give 6 millilitres per kilogram ideal body weight. In a 5'10" male, 440 millilitres. Next, tweak the IE ratio. Dial down the inspiratory time while keeping an eye on the IE ratio. You want that to be at least 1 to 4. Modifying the slope to a steep incline will give fast inspiration, which allows a further prolongation of expiration. Next, it's time to check your flow curves by pressing the curves button until you see a screen that looks like this. If they indicate breath stacking, lower the respiratory rate further. The minimum would be 4 breaths a minute. Finally, perform an inspiratory hold maneuver by holding down the inspiratory hold button. If your plateau pressure is greater than 30, lower the tidal volume to 5 millilitres per kilogram and even 4 millilitres per kilogram if plateau pressure remains high. Plateau pressures should be checked and documented every 4 hours. The guidelines also indicate when to tweak the protective strategy. In head injuries, when raised intracranial pressure is suspected, keep the PEEP at or below 5, ensure the head is raised 30 degrees, which it should be anyway to minimise aspiration, avoid hypercapnia, and keep patient bombed at a RASS of -5 so they don't fight the tube. In the fatigued metabolic acidosis patient, the respiratory rate should be set at least the rate the patient was breathing before intubation. As a side note, these are the patients who would most benefit from NIV pre-intubation, as it would minimise the respiratory component of the acidosis. Post-intubation, the patient should be moderately analgosedated to a RASS of -3 or -4 so that they can breathe up at the rate that their body deems appropriate. These extra breaths should be supported by lowering the trigger to 2 and ensuring there is enough pressure support to ensure a 6 ml per kilo volume. Both of these functions can be found in settings. APO patients and cardiogenic shock patients are part of the same spectrum. APO patients have the blood pressure to cope with a high PEEP prescribed by the protective lung strategy. Cardiogenic shock patients do not. The latter need more help than what a ventilator can offer, as their 80% mortality rate attests to. In the pregnant patient, please ensure that a wedge is in place under the right hip to roll the uterus off the IVC, thus ensuring adequate venous return for adequate cardiac output. Other physiologic changes of pregnancy include a larger tidal volume of 8 millilitres per kilogram of ideal body weight, a faster respiratory rate, 18 to 20 breaths per minute to maintain the same pH, and a low normal CO2. Finally, if the patient is crashing, take the ventilator out of the equation by placing the patient on a bag valve mask. Check to see that ETT is not displaced or obstructed. Check to see that the patient doesn't have a pneumothorax. This is probably done best by an experienced hand on an ultrasound machine. If in doubt, perform a finger thoracostomy. If the patient doesn't have a pneumothorax but has crashed, allow the patient to exhale stacked breaths, which may take a minute or so, and may be helped with manual chest compression. Once resolved, reconnect the patient with all the aforementioned techniques to minimize gas trapping. Finally, once the tube and patient have been ruled out as the cause of the problem, switch to a new ventilator. And finally, non-invasive ventilation. While the nurses will usually use the Savina for NIV, the Oxylog and Savina have the same theory underlying them, so let's continue with the Oxylog as it will reinforce what you have learnt so far. In fact, you will see that we actually have a constant ventilation strategy across adult and peds, volume control and pressure control, intubated and NIV. This NIV strategy was constructed and signed off on with the help of our intensivists and respiratory physicians. To get the Oxylog into NIV mode, you need to press the PC BiPAP button and, in Settings, find NIV and turn it on. What this does is compensate for air leak and render both the volume knob and the respiratory rate knob button inactive. Set the Pmax at 25. The reason why this is lower in NIV patients than intubated patients is that the lower esophageal sphincter is overcome at about this level, so that the patient will swallow air, distending the stomach and impairing ventilation. Start with a PEEP of 5 and an inspiratory pressure of 5. This equates to an EPAP of 5 and an IPAP of 10. This is just to acclimatise the patient. Increase the inspiratory pressure so that the patient is achieving volumes of 6 millilitres per kilogram ideal body weight. So once again, our 5'10" male needs 440 millilitres per breath. If, after 15 minutes, the patient's respiratory rate is still greater than 25 breaths per minute, increase volume to 7 millilitres per kilogram, which would be 511 mils. This can be repeated every 15 minutes until the respiratory rate is less than 25. Though the chart goes to 8 millilitres per kilogram, you can go up to 10 millilitres per kilogram initially until you get the patient under control. After an hour, do a venous gas to see if there has been any improvement. Titrate the PEEP and the FiO2 as per the PEEP FiO2 scale. If the patient has acute interstitial changes like acute pulmonary edema or pneumonia, expect to need PEEPs of at least 10. The morbidly obese are also likely to need PEEPs exceeding 10. In obstructive patients, there are, as you may have guessed by now, two schools of thought without any evidence. You can have almost zero PEEP, usually favoured by intensivists, or you can have a PEEP no higher than 10, favoured by respiratory physicians. Using the PEEP FiO2 scale up to 10 seemed to be an agreeable compromise. Inspiratory hold manoeuvres and plateau pressures aren't possible on spontaneously ventilating patients, so the only other tweaks you can do for your obstructive patients is to lower your inspiratory time, which increases your IE ratio, and to increase your slope, which increases your inspiratory flow rate. Both of these tweaks will increase time for expiration. So that's pretty much it for NIV and for the Oxylog and for this presentation. Thank you for watching.